Good evening, everyone. I am Dr. Riya Gandhi, and the topic for my paper presentation is role of ultrasound versus MRI in the diagnosis of shoulder joint pathologies. So my co-authors are Dr. YP Sachdev, Professor and HOD, Dr. Shubham Gorpade, in the Department of Data Diagnosis, Dr. BVP, Rural Medical College, Loni. So the aims and objectives are to evaluate and compare the accuracy of USG and MRI for rotator cuff, bicep tendon, AC joint, and bursal pathologies to analyze sensitivity, specificity, and diagnostic concordance between both the modalities to identify clinical situations where USG can reliably replace MRI and where MRI remains superior, to formulate an evidence based imaging strategy for shoulder pain evaluation. So, the materials and methods are place of studies, Department of Radar Diagnosis, Dr. BVP, Rural Medical College, Roloni. It is an analytical study. My sample size was 100 patients. So my inclusion criteria was all the patients who were referred to the Department of Radar Diagnosis are subjected to ultrasound and MRI. And exclusion criteria who did not give consent for the examination. So introduction, the shoulder is one of the most complex and mobile joint in the human body and offers a wide range of motion at the cost of stability. So the primary stabilizers of the shoulder joint are the glenoid labrum and the shoulder rotator cuff muscles. This remarkable range of motion makes it prone to various injuries and degenerative conditions such as rotator cuff tears, shoulder impingement syndrome, bursitis, and tendinitis. So here are a few cases. So a case number one, a 76-year-old female came with complaints of decreased range of motion and pain in the right shoulder joint. So here, these are the USG images. So here, this is the greater tuberosity, this is the lesser tuberosity, and this is the bicipital groove. So here, we are not able to see the hyperechoic biceps tendon in the bicipital groove. So this is most likely a biceps pulley injury. And on dynamic evaluation for subscapularis tendon, so we tell the patient to laterally rotate her arm. So while doing that, we can clearly see that there is an hypoechoic area near the attachment of the subscapularis tendon over the lesser tuberosity. So this is likely a partial tear of the subscapularis tendon. This is an MRI image of the same patient. This is an PD fat sat axial image. So here we can see that the biceps tendon is not seen in the bicipital groove and is rather seen here in the articular region. And this is the subscapularis tendon which is attached to the lesser tuberosity. And here we can see that there is fluid signal intensity noted. So this is the partial thickness tear of the subscapularis tendon that is seen on MRI. This is the case number two. A 25-year-old male came with traumatic injury over the shoulder joint and complains of swelling and pain during movement. So normally the acromion and the clavicle are at the same level. And here this is an USG image and we can clearly see that there is mild superior displacement of the clavicle and the distance between the acromion and the clavicle is increased. This is the superior acromioclavicular ligament. And on MRI, this is an PD fat sat coronal image. Here we see that the clavicle is again displaced superiorly. There is adjacent edema noted. We can see that there is sprain of the acromioclavicular ligament. This is the case 3. A 64-year-old male came with complaints of decreased range of motion and pain in the shoulder joint. So here, this is the USG image of the right shoulder and this is the USG image of the left shoulder. Here we can see the normal thickness of the supraspinatus tendon. This is the normal bird beak appearance. And here we can see that there is decreased thickness of the tendon as well as here there is an hypoechoic area. So this is likely suggestive of partial thickness tear of the supraspinatus tendon. Here we should not confuse this with a tear. This is because of anisotropy. So when we make the probe perpendicular to the fibers, this is not seen. And this is how we can differentiate between tears and an anisotropy. So on MRI image of the same, this is an PD fat sat coronal image. Here we can see that there is fluid signal intensity noted at the attachment of the supraspinatus and there is retraction of the fibers of the supraspinatus. On USG, we can clearly not evaluate the retraction, but on MRI, we can evaluate the retraction of the fibers. This is the last case. This is a 70-year-old female came with complaints of pain in the right shoulder. Here, this is the right image, USG image of the right shoulder. This is the USG image of the left shoulder. Here we can see the normal thickness of the subscapularis tendon. But here we can see that the tendon thickness is reduced. There is fluid signal intensity noted here. So this is a partial thickness tear of the subscapularis tendon. So on PD fat sat axial image MRI image of this patient, we can see that there is fluid signal intensity noted here at the attachment of the subscapularis tendon. So this is a partial thickness tear of the subscapularis. So after evaluating 100 patients, these were the results. So the USG performed very well for rotator cuff full thickness tears, biceps pathologies, and bursitis. So USG was limited in detecting labral injuries, deep capsular lesions, marrow edema, and complex multistructure involvement. And MRI outperformed USG in all deep intra-articular pathologies and in characterization of partial thickness tears. So this is the overall diagnostic performance of USG. So for rotator cuff full thickness tears, sensitivity is 90%, specificity is 96%. For partial thickness tears, sensitivity is 78, while specificity is 92%. For biceps tendon pathologies, 91% sensitive and 95% specific. For AC joint abnormalities, 84% sensitive and 94% specific. For bursitis, 90% sensitive and 96% specific. For labral tears, 33% sensitive and 98% specific. So we can see that USG can clearly, reliably replace MRI when full thickness rotator cuff tears are suspected. Biceps subluxation tenosynovitis is clinically likely. Impingement and bursitis needs evaluation. Elderly patients present with degenerative pathologies. And MRI is required when labral injury is suspected to evaluate retraction of tone fibers or internal impingement suspected. AC joint synovitis or bone marrow edema are needed for the diagnosis. And preoperative planning is required. So the conclusion of my study is ultrasonography demonstrated excellent diagnostic accuracy for rotator cuff full thickness tears, biceps tendon abnormalities, and subacromial subdeltoid bursitis, establishing itself as an effective first-line investigation owing to its accessibility, dynamic capability, and high specificity. MRI, however, remained superior for labral injuries, retraction of tone, tendon fibers, estrogen inflammatories, changes, and deep intra-articular or osseous abnormalities. Its comprehensive multi-planar evaluation makes it the gold standard, especially in younger patients, traumatic instability, or surgical decision-making. So overall, USG and MRI are complementary rather than competitive modalities. A structured diagnostic pathway beginning with USG for most cases and reversing and reserving MRI for inconclusive or complex pathology provides the most efficient, effective, and clinically accurate strategy for evaluating shoulder pain. Thank you.